Okay, good morning, everybody. We are going to go ahead and get started, even though a few people are still coming in. But we have just an hour with you today, and so we want to make sure that we get through the material that we have as best as we can. I wanted to let everybody know that the session is being recorded to be put up on the AMCHP website afterwards in a couple weeks. So what we will ask is that if we do have questions from the audience, that we use a microphone so that it can get picked up on the video. And we will do that so that everybody gets heard. So good morning. You all made it. You know, in a time when we're coming from all sorts of different time zones and places, why not add a little extra wrench to it by taking away an hour for everybody? So thank you for being here and joining us this morning. This session is I Did Not Go Into Medicine for the Checkboxes, Levering Youth Engagement, Cross-Systems Partnerships, and Clinical Tools to Help Put the Care Back in Healthcare. And our time together this morning is about using all of these approaches to bring the care back into our healthcare, to move from the must-dos and the checkboxes that we have when we're in clinic with young people to the person-centered, youth-centered care for our well visits. My name is Julie Neitzel-Carr. I am the State Adolescent Health Coordinator at the Minnesota Department of Health. And I just want to do a little bit of framework grounding for us right now and talk to you about the Minnesota Partnership for Adolescent in Health. This is what helps guide us and roots our work around adolescents in our state. Our adolescent health goals are to improve the well-being and health of youth and young adults. And when we're talking about adolescents or youth, we're talking about ages 10 through 25. And that is based on what we know about youth development and their brain. Our goal is to build and maintain strong partnerships with other state and local public health agencies, youth-serving organizations and professionals, providers, schools, faith-based organizations, policymakers, and of course, our young people. And all those that are interested in supporting the health and well-being of adolescents and young adults. We have our priorities for adolescent health, and it was interesting when a couple years ago, we went on a strategic plan journey, and we went around the state and held multiple listening sessions about what is adolescent health, what is important, what works, what do we need more of, and our partners helped us identify 10 priorities for adolescent health, and that's what you see in the colored boxes on the screen. The same time that we were doing this, the Office of Adolescent Health was also going on their journey and creating their Think, Act, Grow initiative, or TAG. And we quickly learned that our 10 priorities lined up really well with their 5 essentials for adolescent health. So you can see their 5 essentials in the white boxes, and then our 10 priorities that fit beneath those essentials are right around there. Today is not about all of that, and although we could weave some of what we'll be talking about today into more than a couple of our priority areas, our time today together will mostly touch on the access to high-quality, teen-friendly health care, which includes improving the responsiveness of physical and mental health care for our young people, and strengthening and creating effective governmental systems, policies, and programs that are designed to support the health and well-being of our young people. So many of you either have participated or have heard about the Adolescent and Young Adult Collaborative Innovation and Improvement Network, or more commonly referred to as the IACOIN. Minnesota was a part of Cohort 2, so Minnesota, along with 6 other states, which are highlighted in blue, participated in this project that was run by and facilitated by AMCHP, University of California, San Francisco, the University of Minnesota State Adolescent Health Resource Center, and the University of Virginia National Improvement Partnership Network. And together with the states that participated in Cohort 1, Cohort 2 built on built on our increasing our well visits for adolescents and young adults. And that brings us to our objectives for today. So today we will be describing key lessons learned in Minnesota's experience in this coin. With the help of our young people and other partners, we learned how to move from that checkbox care to the youth-centered and youth-focused care at both the state and at the clinical level. We will share our key partnerships and strategies in policies, marketing, clinical supports, and youth engagement that helped our healthcare providers put that care back in healthcare. We will address the utilization of the well visits, which includes identifying what the value is. We will talk about the quality, which brings us to the youth-centered care, and we're going to talk about the policy that affects the young people and their care. It is my pleasure now to introduce my colleague Katie, that is going to introduce herself and keep us going.
Good morning. So I'm Katie Shala-Leshek, and I also work with Julie at the Minnesota Department of Health. I'm a pediatric nurse practitioner. So my background is in primary care, and I did general pediatrics for about 10 years in a hospital-based community clinic prior to coming to the health department about 7 years ago. So what I do now is statewide training and consultation for EPSDT, which is early periodic screening, diagnosis, and treatment. Not EPSTD, as Julie always says. But she's the adolescent. Never mind. All right, so my focus is on really for kids that are eligible for Medicaid, meeting with healthcare providers and others and helping them try to achieve the standard of care. So based on the Bright Futures schedule, trying to make sure that they have tools that they need and training to be able to accomplish that with evidence-based practices. And so really a lot of that has been focused on the checkboxes. So I'm going to describe for you how this transformed my own view on my clinical practice, but also how I do my work with our team at MDH when we're interacting with clinics around the state. So I am not an adolescent health expert. If you want that, you need to talk to someone else. I actually am better with early childhood. That's kind of been my area, focusing on early childhood development and social emotional health and mental health. In practice, I definitely did see adolescents, but in our typical day, it was much more heavy on the early childhood. So I think the kind of the unique aspect of what we did here, for example, we had clinics in Minnesota, or a coalition actually, that really did a great job of focusing on reproductive health clinics for adolescents. But this project focuses on primary care. So with your average primary care provider, whether that might be a pediatrician or a family medicine doctor, or a nurse practitioner, or a physician assistant, how do we support them to feel more comfortable with adolescent care, to meet the clinical measures, but really to do that in a way that's more meaningful both for the young person and for themselves and the family. Recently, this past summer, I guess it wasn't that recent, it feels like a long time ago, summer, I did a presentation at the Minnesota Academy of Family Physician Conference, and I shared kind of the typical presentation, and one of the family medicine docs at the end said, you guys are telling us to do too much stuff. We have like 20 minutes if we're lucky, and this is too much to cram into a visit. How do we get that care back in healthcare? And so what I'm gonna do with Julie in the next few minutes is just try to highlight some ways that we worked with statewide partners, national partners, clinicians to learn about from young people their thoughts on how to do it, to test these things in clinic and see what actually worked, and then cover some of the policy and state level supports to support that work. So it'd be helpful for us to know who is in the room. Can I see, are there other clinicians in the room who provide primary care services? Okay. And then what about maternal child health at the state level? And then health educators, social workers. Who am I missing? There are other people. Adolescent health. Yeah. Community agencies. Thank you. Family-led organizations. engaging families and youth in systems. Thank you. Yeah. So you just hit on something that was, I think, yeah, okay, we'll be talking. So that was a real key thing for me, is this honestly was the first time I have experienced authentic youth engagement and how that can actually transform the way we provide care. So we'll talk about that too. All right, so another question. This will make sense probably later, but just think to yourself, if someone gave you a $10 gift card to your favorite coffee shop, write down or think in your head or share with a partner, what would you order? Like, don't pay attention to calories, don't pay attention to dollar amount, just think about what is your cup of coffee that you would order, or if you're not a coffee drinker, tea. Okay, share it with a partner. So that was animating, right? I hope you actually have your caffeine in front of you. Anyone care to share their favorite coffee drink that they would get right now? What's that? Hazelnut latte. Anything else? Any other orders? Any non-coffee orders? Yes? Chai latte with almond milk, please. All right, thank you. We'll talk more about this later. All right, so when we look at, the Department of Health, we are the health consultation, but it's the Department of Human Services in Minnesota, that's our Medicaid agency. And so we have an interagency agreement with them, and of course our focus is trying to get that participation ratio up to 80% or higher. That's our federal goal, and our kind of the holy grail or whatever. Very few states are able to achieve that. It's easier in infants. They come in. So this graph shows in any given year what percentage of kids that are eligible for Medicaid make it in for at least one of the visits they were supposed to come in for during that time period. And so 91%, more than 90% of infants make it in. I hope so, because they should be coming in for 5 or 6 visits. So 90% have come in for at least one. There's lots of immunization visits. Whereas if you go down to the young adult end, we've got 40% of Medicaid eligible young adults coming in for a well visit at least once in a period of 2 years, because that's what our periodicity schedule said at the time that this data was collected. So it was a statewide goal to really focus in on adolescent and young adults. So that really, our Medicaid agency was on board with us as a good partner. Other partners that we engaged, it was kind of this perfect storm, a good storm of readiness to work on adolescent health. So we had been connecting quarterly with our health professions academy, so the Minnesota Academy of Pediatrics, Family Medicine, Pediatric Nurse Practitioners, and Physician's Assistants. We had invited them starting a couple of years ago to meet quarterly, the academy representative and clinician representatives, to talk through policy and other issues around EPSDT, which in Minnesota is called Child and Teen Checkups. And so we had that existing relationship with them, so when it came to time to talk about joining us in this partnership, they were on board. Adolescent health was already a priority for them, and I think having it be a national project just kind of elevated their interest in that. But they were excellent partners, and then right away we were able to get a couple of clinicians from both academies who were ready to go. These were clinicians who were kind of the first adopters. We were familiar with them already. They had done early childhood stuff in the past, but now they were interested in really working on their adolescent preventive care. And incidentally, as a healthcare system, they had already been working on their children's health initiative that included some very specific work around adolescent health. And then we had local public health, because in our state they do child and teen checkups outreach to families and providers. But we did have this kind of gap around youth engagement. We knew that several local programs had youth boards, but we weren't sure how we were going to approach that. And so basically what we did with that amount of money that we got to join the coin, which wasn't a huge amount of money, but we decided to dedicate that to engaging young people and paying them for their time. The clinics did not need money to participate. It was almost more work for them to accept money for participation. They had other reasons that they wanted to participate. So Julie's going to share with you a little bit more about our project approach, and then we'll get into the juicy details of the tools and approaches.
Thanks, Katie. So the scaffolding that we used for this project was our key driver diagram. And our ultimate goal was to increase the rates and the quality of our adolescent and young adult well visits. And we wanted to do that by increasing the well visits and the satisfaction of care. So our key drivers were, again, the awareness and the utilization of the adolescent and young adult well visits. We wanted to then look at the quality of the well visits for both the youth experience and also for the clinical quality. And then we wanted to look at the policies that support both the utilization and the policies for the well visits. And so here are our strategies and interventions, and what we're going to do today is highlight the ones the strategies and interventions that we really found were the most impactful. So we're going to go in a little bit deeper to those throughout our time. And now we're going to start with the utilization and the value of that.
All right, so we needed to find out for young people what is the value of going in for a well visit in order to help increase utilization. We wanted to increase awareness. And so the reason for that is the previous cohort for the Aya coin had done some work in focus groups. I think it was Iowa that did a focus groups with parents and young people. And those focus groups revealed that preventive care was just not a concept. It wasn't a thing that they were thinking about. Babies, yes, they have to go in for their shots, but why would I go into the doctor if I'm not sick once you hit a certain age? And so, maybe for a sports physical, I might go in, or if I had asthma and I needed to get that checked up, or if I was really sick, then I would go. But we were dealing with the understanding that for young people and their parents, having a well visit might not be a concept at all, and if it was, it definitely wasn't at the top of the list unless there was some other reason bringing them in. So that's what we were dealing with. So we wanted to figure out, okay, if young people knew what was part of a well visit, is there anything within that that brings value? So granted, they have to go in, they have to sit in the waiting room with a bunch of screaming snot-nosed kids, they have to go into a cold waiting room and talk to a stranger for 15 minutes about really personal stuff, possibly in a hospital gown, get a hernia check, which is never any fun. And, so that's kind of maybe what we were dealing with and facing. So is that all there is to a well visit, or could we find something that was of more value to young people? And so we started with a marketing campaign. So our largest county, Hennepin County, had a Medicaid budget for using administrative funding dedicated to a statewide marketing campaign. So they were really eager to join us in the coin because they wanted to figure out how to focus the campaign. And so it made sense to focus on young adults and older adolescents because those had the lower rates of well visits. And so we focused on age 16 to 20. We worked with Glenna Shea. That was one of the benefits. Of course, we know her because she's from Minnesota, but she helped us figure out some marketing, get connected to the ideas and a company around marketing. And so the county was able to contract with them. And they actually did virtual focus groups with young people from around the state, a diverse kind of collection of young people from different parts of the state that represented different types of backgrounds. And so they asked them questions about, they gave them kind of an idea of what could happen at a well visit or what was supposed to happen at a well visit, and wanted to hear what was the value in that. And also what messages resonate for young people and how to get that message out. And so, long story short, they came up with themes that were important to the young people, and they developed a campaign. They worked with the young people to develop the look, and it ended up being this emoji equation where you kind of have to look at the emojis and figure out what it means. And then there's a website that it brings you to that just tells you more about the well visit and help you take the next step. So the two top themes that came up were mental health, both for themselves, their friends, their family, and then the other one was sexual health. That was a big one. This is the tame version of the emoji equation that came out. There were peaches and like eggplants and rockets and all kinds of stuff, but that did not pass muster with the communications people, let alone the commissioners. So there we have it. So this campaign went statewide on Facebook, Instagram, bus signs, and it was targeted in communities that had a higher population of Medicaid-eligible young adults and, like around community colleges and high schools. So that was our kind of initial step into looking at increasing public awareness about well visits, that they were free, and that there was things of value there. And then next we moved on to figuring out how to improve the quality of the visit itself. Yes, the clinical quality, but most importantly, the experience that the young person would have going in. So this is not how young people come to their well visits. They don't come rushing and smiling. But we wanted to figure out, could we approximate that? Could we get closer? If you're talking from a clinician's perspective and as a person who's doing training with clinics, we're very familiar with the value to the clinic around well visits. Number one, meeting quality measures. It's really important in the well visit to document everything that happens, to meet JCO requirements, to meet whatever clinical measures you have to report on, and then you have to document all that stuff and code it appropriately and bill it appropriately so that you can get the maximal reimbursement to keep your clinic moving, right? So that's kind of, if you're asking about value of a well visit to a clinic manager, that might be some of the answers you get. But we're really focusing now on, for the young person, what is the value? For the family, for their parent or guardian, or other adults who care about them. And then really also, what about the clinic staff? What about the front desk? What about the rooming staff? What about the provider? What do they want to get out of a visit experience? So this is what we're moving toward. So Julie?
So I really love this comic. If you are in adolescent health at all, Zits, the comic strip, really gives you wonderful, wonderful things. And so what I love about this comic is Jeremy is the adolescent, and he is at the pediatrician and with his mom, and he's stuck sitting in a child-sized chair, and mom turns to him and says, "What exactly is it that bothers you about seeing the pediatrician?" And I just think that this comic really brings in the importance of youth voice and asking them and getting their feedback for what it is that they need. So as Katie had mentioned, the stipend that we got for doing this project, we funneled straight over to doing contracts with young adults to be our representatives and to help us guide this project. And so we put out a statewide call for applications. We put together a very simple application process, and we were hoping that we could get 8 to 10 people to apply, and we ended up with well over 60 applicants. I think it was like 67 applicants, and we were blown away with the young people that wanted to help us and go on this journey with us. So this is who we ended up with. We ended up with these 9 wonderful young adults that all have diverse backgrounds. They were from around the state, and they had a lot of amazing things to say. One of the first things we did with them when we gathered in person was we had a day-long retreat. And one of the exercises that we did is we ran them through a clinic visualization exercise. So everyone got comfortable, they closed their eyes, and I asked them to think about their last visit that they went into a clinic. And we started with making the appointment. How did you do that? How did it feel? How did you get there? Did you bike, walk, drive, take the bus? Who was with you? And we walked them through getting to the clinic, checking in, getting roomed, your time alone, who was with you the entire time, when the clinician brought you in, follow up, and then when you left. And then afterwards, we heard from them what their clinic was like, what their experience was like, and then we also talked about how do you wish it was? What happened, and then what do you wish happened? And what we really heard from them was, please know that I am a person and that I am here. Please know that I am an individual and I have something to say. Talk to me and listen to me. And so we did, and that is what started our beginning foundation of how we're going to work with these young people and how they're going to direct and inform our project. And as Katie told you, she would circle you back around to your coffee.
All right, so at this retreat, it was a full day. We got to the early afternoon. People were looking a little bit sleepy, so I decided I wanted coffee. So I decided I can't get myself coffee without getting everyone else coffee. So I I asked them, I sent around a piece of paper and asked them to just write down what kind of coffee they wanted. And so, the first young person took the paper and was like kind of just sitting there with a pen looking at me. And I was like, no, I mean, like, if you could order whatever coffee you wanted, just, go for it, whatever you want. So after really encouraging them, the paper went around the room. It took a really long time, and this is what came back. My favorite was the young guy who said, I would like a medium hot white chocolate mocha with an extra shot of espresso, 2% milk, whipped cream on top, 1 stir stick, 2 sugar packets, sugar in the raw, if they have it. So I just thought this was a really good representation of individualized, patient-centered care. Like, if you think about your own coffee order, if you think about it might change on a given day. Yes, that's what you wanted today, but it might be different tomorrow. It might be different in the afternoon. You might go for a decaf, whatever. It's kind of a simple way to bring it back down to, we all have our individual preferences. And if you're here for coffee, like, I'm going to give you the coffee you want. I could have come back with one of those boxes of black coffee with creamer on the side. Somebody might have drank it, but no one would really enjoy it, let's be clear. So that was just a good kind of representation of patient-centered care. So, and that day when I just sat there listening to what was going on, I wasn't actively engaged in planning. This is the day that transformed the way I viewed my role in training providers and moving away from that checkboxes approach of this is all the stuff we have to accomplish to what can we do in ways that are actually doable in a clinic setting to move toward youth-centered care and really recognizing them as an individual, not just a ball of risk around sex and drugs and whatever, but as an individual developing young person with their own goals and interests in life so that we can better support whatever it is that they need. And so when we talk about transforming care, we want things that are recommended by youth, number one. We want things that are tested by clinics and actually possible. We want things that meet existing quality measures. We don't want to ask them to do more stuff than they already have to do. We just want to make that easier. And we want to make sure those tools are free whenever possible so that they don't have to have it go through the rigmarole of getting administrative approval around those things. So number one, just in case you're not a clinician, there's a lot of stuff that goes on in a well visit: measurements, risk assessments, validated screenings, referrals for concerns, not to mention the physical exam. So there's a lot to take place. And generally speaking, it's real common for clinics to have 20 minutes per visit regardless of what the visit is for. Sometimes some clinics will give a little extra time for an adolescent, but not necessarily. And so what we're going to do is just quickly highlight these tools that we looked at. Number one, youth recommendations. What is it that brings value to the young person? We'll talk about that. We'll talk about the particular tools that the clinics tested out. And then we will also go into a couple of tools that help clinics more efficiently meet the quality measures that they already have to meet and support standardized mental health screening and HIV universal screening, because those were two of the most challenging issues that clinics identified. And so when you do all that stuff, the goal is you end up with a young person who has a real experience as a human being with another human being in a visit. That's the goal. And number one, they want one-to-one time with their provider, not looking at the computer, but actually having a conversation. And when they get that experience, they're more likely to come back again and presumably continue into young adulthood with a sense of some benefit of going in for preventive health care. But not only that, clinicians get a lot out of this as well. When youth voice is involved, a lot of times clinicians really want to do the right thing, right? But they have to have administrative support to do that. And so when you have youth voice that's telling you this is important, that gives clinicians extra leverage to move changes in their clinic setting. When you give clinicians tools to get all this stuff done on time, that gives them more time for their conversation with the young person so that it's less about the check boxes and more about the conversation. So we'll go into that a little bit more. So Julie's going to share about the first tool.
So things have aligned a couple different ways in Minnesota. When we were doing our strategic planning, TIG was doing their strategic planning, and we got to collaborate and work together. When we were doing this project and we were looking for a tool for clinics for our young people to use to do clinic walkthroughs, University of Michigan's Adolescent Health Initiative had this tool that they were looking for people to pilot and check out, and so that worked for us really well. And so we teamed up with the Adolescent Health Initiative and piloted their youth-led center assessment tool. And so we had our young adults do walkthroughs of 3 different clinics. One of them was a pediatric clinic, one of them was a primary practice clinic, and then that primary practice clinic also had a school-linked health clinic, and so we were able to do all 3 of those clinics, which was really exciting because they were all very, very different clinics. What our clinics learned from this walkthrough were that they need to have youth-friendly resources. Not so much the school-linked clinic, but the primary care and the pediatric clinic. They need to know that they need to have LGBTQ friendly information up, and that needs to be very obvious. And this was shocking to one of our clinics because they were like, well, wait, we have a staff member that is like a well-known LGBTQ advocate, and he sits on all of these boards, and he does all this, and we're like, well, nowhere in here does it show or that you are LGBTQ friendly, or that you have an expert on staff, or you have a place to be? And they're like, oh, we didn't know. So they had what they knew about their staff, but they were not translating that information at all to any of their patients. And so one of the things that then came up is the health systems, parent companies of the clinics had very strict rules on what could be posted in the walls and what their clinics were supposed to look like and all of that. And they really wanted it a sterile, professional office space. And so that did not leave much room for our young people to see stuff up on the walls or in their rooms that felt welcoming to them and that they could relate with. And so what happened was our young people said, we want information and we want to know that this is a safe place for us. And so their solution for that was to create our resource flip chart. And so what our young people did is they came up with the topics that were really important to them, that they wanted to know they could get covered or they could talk about at the clinics, and we had the clinics identify things that they are able to cover in these visits, and they created this flip chart. And so then our young people reviewed it, they added to it, they edited it, and now these flip charts are used in all of our clinics when the young people get roomed. And so to keep them just off of flipping on their phone, they have some resource to look at that includes how to talk to your provider, information on healthy relationships, information on GLBT questioning young people, and then also things on mental health and weight and food. We in public health love our surveys, and we love our evaluations. And so what we did is when our young people leave a well visit, they would have our satisfaction surveys that we would ask them to fill out as part of the project. And an interesting thing that we learned is we started out all techie with this, right? So we had the posters with the QR code, so you could just scan it and it'd bring you right to the survey, or we had a really short website where you could log on and get to the survey, and we're waiting for all these surveys to come in, and we were not getting any surveys from the young people. We're like, well, what's going on? We're using this technology and we're being all hip and cool. And we realized that they wanted paper and pencil. And so the minute we still had the option to do it electronically, but the minute that we started putting paper surveys in the rooms, we were getting stacks of surveys coming after us. So that was a learning curve that we had for us. And so we had 3 different surveys that we offered for different ages. We had surveys for young people that were 10 to 13, and then in our middle adolescent age up to 17, and then for our young adults. And so what we learned from these surveys was we were really looking at the youth friendliness and some markers that we that we had that were identified that were important to become a youth-friendly site. So whether the clinics were welcoming, whether the front desk, the staff was good, if they know about confidential care, and if they were comfortable with their providers. And for the most part, we did pretty good, but we were able to identify our potential areas for improvement, which always includes the assurance of confidentiality with our patients. Our patients really liked to talk privately, and some of our practitioners were surprised that even our younger patients would really like that one-on-one time. And then they wanted to increase their health literacy. They wanted to know different skill sets for how to contact the clinics, and again, knowing about confidential care. So things that we heard from our young people, what they liked about it, is that I can talk about my struggles. Our young people said that the doctor spoke in a way that they could understand and that they were listened to. Our middle adolescents, again, talked about privacy, being safe with their doctor, and the opportunity to ask questions, and that they felt heard and the questions are being answered. And our young adults really liked that they were treated as an adult, and that they felt safe and heard, and the environment was welcoming and friendly. What could have made things better? Where our young people said, no shots. And so we couldn't meet that need, but we heard also that they liked to know that the shots were coming. So they liked when they got into the room that they knew what to expect during their time there. One of our favorite feedback is from a young person who said, I wish I could have gotten a little bit better of a checkup in the privates, just to be sure about what the doctor said. And I love that quote, because what is it really saying is, I just want to know, am I normal, right? And that's a question that we all have, am I normal? And this is a time and a place that they can come to get assurance, and yes, they are. Our middle adolescents that are always eating us out of house and home wanted snacks. And they want to be able to have that one-on-one time and talk in private, and they also would prefer no shots. But they did identify that they wish that the space was more teen-friendly. And then I love our young adults. They just want coffee and puppies. And really, who doesn't just want coffee and puppies? So we heard from many of them about talking about the one-on-one time and how they're craving that and they want that and it's important to them. So Katie's going to come back up and talk about that time, and while we're doing that, you can hear from Jeremy and his visit with his doctor as well.
So in case you can't read that, the pediatrician says, Mrs. Duncan, would you step out of the room while I ask Jeremy some questions? Oh, okay. I mean, absolutely, doctor-patient confidentiality, right? No problem. So she walks out. She's listening at the door, isn't she? What did you expect, said Jeremy. I am not, said Mom. Anyhow, probably never happened like that, but it might have. So I just want to highlight about those surveys. That was a required part of the COIN. So those surveys that was through AMCHP and that broader national project. So those are available for everyone to use. Our clinicians were pretty excited about that because they do have, at least in Minnesota, they have to do this kind of patient satisfaction survey process, and they do it for kids under 12 through their parents, and they do it for adults, but they don't do it for adolescents because of confidentiality issues. So this, I know it sounded weird, I had never heard of it, but this was a way for them to get that feedback. And one of the surveys said something like, the front desk lady was crabby, and that was a known issue, and that gave them a little bit of objective feedback to address that issue, because that basic welcoming feeling when you walk in, you've probably felt it yourself when you walk in somewhere and you don't feel welcome. That's a huge issue, especially for adolescents. So one of the quotes that was, if I don't know if you were able to read it, it was at the 14 to 17-year-old age range. One of the patients said, what would you have liked? What could have improved the visit? And she said, if I could have gotten more private time with my doctor. My mom felt a little overbearing, is what the quote was, and that was a direct quote from a young person. But what came up over and over again is the need for young people to have a conversation with their doctor and to have some time for privacy and to feel listened to and heard. And so as a result of this project, we really are honing in all of our work now and supporting having a standard at every clinic visit for every young person to have one-to-one time with their provider. One of the clinics did a provider survey, and not surprisingly, we learned that It's a relatively small practice. There were 9 different providers, and they all had a different standard about at what age they would typically offer that one-to-one time. And it was, I think the youngest was probably around 12 or 13, and the oldest was 18 or higher. And then some people just made a comment about, well, if they seem mature enough to need it. And I think the problem with that assessment is you can't tell. That goes into all kinds of bias. Like, I could list about 20 different kinds of bias that goes into when you're trying to decide if a patient is mature enough to need to talk about sex or drugs or whatever. But the number one thing for transition, there's been a lot of focus around sexual health and that kind of thing as a reason to have that private time, and that is important. But really it's about transition and the young person developmentally gaining the ability to take charge of their own health well before they turn 18. Because once they're legally required to manage stuff on their own, it's not like some developmental switch flips and they know how to do that. So we really need to help support them and their parents throughout that time to do it. And it creates that opportunity to increase the value of the visit for the young person, which is the conversation. And then we were also wondering, especially in primary care, it's one thing if a young person is going on their own to a reproductive health clinic, but in primary care, how do you really engage families? Like, parents need support too. Adolescence is a challenging time. You don't know, is this a normal behavior? Does my kid hate me? Are they depressed? Is this normal? Is this not normal? And so parents also need that support. And so not only do we need to give young people time to share their concerns, I like to, when I do clinic visits, I like to step out of the room with a parent for a couple of minutes and give them a chance to mention any concerns that they didn't feel comfortable mentioning in front of their child. And also I ask them, what have they talked about so far with the young person about dating and relationships and smoking and whatever? And that gives me a sense right away for, a lot of times it's, well, I know I should be, but they're kind of my baby. I feel like I don't need to do that yet, or I don't know how to do it. So you can offer some support, and right away you also get a sense of their values. And I think it's really important to understand that context that the family is coming from and support what's happening around that. All right, so with the one-to-one time, we're really advocating to start that at 11. And part of the reason is if you look at the Bright Future schedule, they indicate STI risk assessment starting at 11. And so theoretically that should be done in a confidential conversation, at least part of that. But the thing is, like, 11, they're a baby, right? But it's really a sweet spot developmentally, because by then they definitely have some body changes. A few years back, I read a research article that talked about the age of pubertal development starting 1 to 2 years earlier now compared to what it was a few decades ago. So kids are developing. A lot of girls already have their periods by the time they're 10 or 11. And so if you're gonna wait till 13, the magic, teens, to do one-to-one time, you're running late. And at 11, they're developmentally, they're embarrassed to talk about their bodies, but they definitely have questions. So if you bring it up in a way, they're gonna be like, oh my gosh. Like a common question, believe it or not, in clinic, I'll get, when I step out of the room, the mom, like with an overweight boy, I'm sorry about having this on video, but this is a common clinical thing. The mom will ask if his penis is too small. And that's a real concern. And so when I do the physical exam, I check out, it's a head to toe exam, and then I reassure the kid that everything looks normal, including in their private area. And it's a lot of times just a developmental thing, an extra fatty tissue in the belly or whatever. But this is an example of a developmental question that comes up at that age. But it's also a really important time to talk about vaping because it's going on like crazy in middle schools. It's also an important time to talk about just general identity. By this time, gender identity is settling in real firmly. There might have been some variations, but this is an important thing to talk about as well. But I would advocate that for the young adolescents, you're spending a lot of this time with the parent and the young person providing education around smoking, vaping, whatever, the whole 9 yards, but still giving the young person a few minutes alone to talk about that. Once you move into middle adolescence, like 14 to 17, you're definitely giving more time for a private conversation and addressing all those issues that are covered under minor's consent. I want to backtrack a little bit. If you do find an 11 or 12-year-old or a 13-year-old that is sexually active, there's an extra high concern or risk for non-consensual activity or exploitation or that kind of thing. So it's really important to be thinking about that at those younger ages especially. And then once they hit young adulthood, if they come with a parent or a partner or a friend, welcome them and, introduce yourselves, find out if there are any particular concerns, and then ask them to leave the room and really spend pretty much the entire visit one-to-one with that young adult who's there for their care, unless the young adult prefers to have the person in the room with them. In one of our sites, our clinic sites, the pediatrician talked about someone in their practice who was an internal medicine doc who had young people would come in their 20s and they would never give them time alone during the visit. They'd come in with their parent. So that's not okay. So it's about having a clinic standard and making it easy for providers to do that. So we'll talk about some tools to do that. The CDC actually has a really great parent handout about why it's great to have one-to-one time between the patient and the provider during adolescence. So that's something you can download. And on the slides, if you download them from AMCHP, you should be able to click on the link. And then we also, based on what one of our clinics was doing, we developed a letter template that clinics could use to give out at age 10 or 11, saying your kid is getting older, we definitely value your input, and we want to be your partner in your child's care, and we're going to have one-to-one time with your child during the visit. That's just a clinic standard, and that gives your child a chance to start learning how to take charge of their own health. So it's that clinic-wide communication and transparency is really important and is a good support to implement the one-to-one care. So in our project, the COIN project, the clinicians heard the young adult reps say, really, I want you to just talk to me like I'm an individual, like I'm a human being, like I matter, right? So the clinicians kind of pushed back and said, yes, we buy into that, but what specifically? Like, what kind of questions do you want us to ask to get at who you are and what you're interested in, what you needed? And so our young adults actually came up with a list of questions and conversational ideas. An example is, try to ask them to list what they think is going well right now in their life. So having a strengths-based approach. To understand the patient, you need to talk about their family. Family relationships can really make or break a person. And then mental health is a huge concern for a lot of us, but a lot of times it's not recognized as something that we can talk to our provider about. So that's an example, and that's something that we make available on our website for providers. And then, of course, confidentiality came up a lot. We talked about it yesterday. That was a great session. And so we are getting out more information about Minnesota's confidentiality and minors' consent laws to providers. So that is a little bit about the one-to-one time, the value, how that creates value for clinicians and young people and parents. The third thing was looking at policy changes. What could we do at a policy systemic level, at the state level, and at the clinic system level to really support that increased utilization of well visits and higher quality visits? And so the first thing that everyone agreed to was that our old periodicity schedule that said visits were every 2 years needed to change to align with Bright Futures. And so our Medicaid agency was on board. So we switched it to every year. And we updated a couple other items on our periodicity schedule as well. And that will mess up our CMS 416 rates for a little while, which is the report that we're all looking at in terms of participation ratio, because our formula is going to change. So we did it at the beginning of the federal fiscal year. And so we'll have to compare. We'll do our own calculation to see what actually happened with the rates when that happens. But the problem with having every 2 years on there, yes, we would have paid for every year, but clinicians weren't sure about that. They weren't sure if Medicaid would cover yearly visits. And so that was just saying, yes, we definitely want young people to come in every year. So that all is wonderful, right? But you still have the clinician with a 20-minute visit. And I do work full-time for the Department of Health, but I pick up clinic hours, which is proving to be really important to keep my brain like in a realistic space. I work at an FQHC, and one morning I went in and I had 7 adolescent well visits in a row. And I can tell you that is not possible. And there's 2 reasons. One is because the stuff wasn't ready. when I came in the room. Like, the MAs were confused about which screenings need to be done at what ages. The front desk had given, one kid who was 11, I don't remember, but anyhow, getting the right screenings and all that stuff. But really with scheduling, what has to happen if you're really stuck on those 20-minute visits is you have to alternate it, like a well visit and an ear infection and a rash, and then a well visit. So there are scheduling things that can be done. The other thing is using clinical tools, and that helps you both get at the required risk assessments, but it also really helps focus the visit efficiently on this young person and what they need today and what their priorities are. So I'll talk about that in a second. Pre-visit planning, making sure everyone on the staff knows, and you have set up ahead of time all the different screening forms and papers that need to be filled out, so that when the provider walks in the room, that stuff is done, and they're able to scan it and see what the issues are, and that helps. It doesn't replace the conversation, it helps focus the conversation and start the conversation. So that's a great tool. And then making sure that every young person has that one-to-one time. So the health questionnaire, for MDH for a long time has had this teen screen online. We changed the name because people thought it was a validated screener, which it's not. It's just really a health questionnaire that gets at like exercise and nutrition and sexual activity and kind of the full range of adolescent health issues. And so our clinics are using that as a tool, the clinics that participated, and really feel like it's important to help get a sense of what's going on with the young person. And we're also updating this form in two ways. One is just very practical. When I used that form in clinic, I had to read through every question to figure out if a yes or a no was a good thing. So we just rearranged the questions. So at the top, if the question is above the line, a yes is encouraging, and below the line, a yes means more conversation is needed. So it's a very simple change, but it saves you like 2 minutes just being able to scan through that. And then really being careful about confidentiality explanations on here. This form is voluntary, you don't have to answer everything. And then we wanted to, so we're working on that, and that will be up soon. The other thing we did to support one-to-one time in the clinic visit is we provide documentation forms for well visits for Medicaid, and those had been way overdue for updating. So when we updated our forms, we included in the anticipatory guidance section a reminder for clinicians to talk to the 10-year-old and let them know that at their next visit, they're gonna get time on their own with the doctor. And it says at every visit, and then starting around 16 or 17, it starts to trigger the provider to think about more of that transitioning and reminding young people and parents what will happen legally within the next couple of years. And then we developed some brochures to go out to families and youth to encourage them to talk together ahead of the visit to figure out what is it that they want to get out of the visit, and it gives them kind of an idea of what they can expect. Real quickly, sports physicals, we ended up talking with the Minnesota State High School League medical director, and as it turned out, we didn't know this guy before, but he happens to be on the AAP National Board looking at pre-participation physical exam. And so we came in with the idea of how do we get every sports physical turned into a well visit, and he kind of turned that on its head and said, you know what, every well visit needs to be a sports physical. And so it just gave us a very different perspective, and so we'll be looking at that too. All right, Julie, should I close this out? Okay. So in summary, we had partners around the state, and in your state, your Medicaid agency will definitely be interested. Clinicians are interested in this type of model, is what we learned, and there are doable ways to do this. For young people, the number thing we heard from them was not yes puppies and no shots, but really talk to me, listen to me, and that's a key thing in the clinical practice. Setting one-to-one time during the visit as a standard for every single young person, and really providing the clinical tools to support that happening. Because if it doesn't happen well, it doesn't happen really at all. If you're interested in looking at some of the tools, we don't have everything posted online yet, but we have a lot of these tools posted online on our Child and Teen Checkups website for adolescents and young adults. So thank you for your time, thanks for your interest, and we have just a few more questions, or minutes for questions. We have about 5 minutes, if anyone has some.
If there's any questions.
I do have a question.
Oh, hang on, Jessica, because it's being taped, it has to be.
Great, thanks so much for that presentation. You mentioned that your providers are required to do surveys, and they've been doing it for under 12 and then adults. Where is that requirement of doing surveys coming from?
That actually came from our state, it came from our state statute around healthcare reform, and that requirement has actually now gone away, but the practice seems to be sticking so far.
Was that a Medicaid?
It was not a Medicaid, it was through, we have it's called SQUIRM, State Quality Improvement Reporting, something, SQUIRMs. And so those are required measures that clinics have to report on, and there's a website where the public can look and view who's doing what. Yep.
So a couple questions. The first two are yes, no. Have you found motivational interviewing training to be helpful for clinicians?
Definitely.
And do you find that you had changes in your EBSTAT rates after the program happened?
We don't know yet. We will. We have to submit in April, and I think we get our data in June through DHS. So we are hoping to see an increase in rates, but also know that when you have big policy changes like this, it takes time for people to catch up.
And what are your efforts for collaborations with school-based health centers, reproductive health centers, and those communities that don't have a primary health care physician to do well visits?
So in Minnesota, we have the Minnesota School-Based Health Center Alliance, and each of our, there's 5 different entities that run the almost 30 clinics that we have in our state, and some of them do the well visits, and some of them just are not set up to do that yet, but those that do them, we are in close contact with, and they do our child and teen checkups, and so they're part of this as well.
Another thing that we have is we actually train local public health nurses to do complete well visits under Medicaid for young people that don't have access to primary care. That's becoming less and less of an issue in Minnesota. However, it is still an issue. Our next step is really focusing on rural providers, because the clinics that partnered with us were early adopters, meaning they're used to doing this kind of stuff, and they both came from large health systems that have a lot of support. And so our next step, and what we're actively working on, is how to better support smaller clinics in rural areas. There's a lot of different issues that come up, i.e. the doctor knows my parents, the nurse knows my parents, whatever. So we'll be looking at that. Because that's, as an example, our mental health screening rates, even though it's required currently, about 80% or more of urban clinics are doing it successfully, whereas about 50% of young people going into rural clinics are getting mental health screening. So that's our next step to focus on.
We have 2 more minutes. Are there any other questions? Okay, thank you for starting your morning with us today. If we didn't already get your coffee, I'm sure that our conversations today have brought coffee on the mind. And enjoy the rest of your sessions.